Hello everyone. So we are back with management of AUB. In our last lecture, I talked about the update on classification of AUB, what is new, and we talked about FIGO 1 and FIGO 2. I hope you have listened to that. If you have not, first go through that and then we will come to management, and this is part 1. Why part 1? Because AUB is a vast topic. As we all know that management of any disease includes diagnosis as well as treatment of the same. First of all, how do we diagnose? There are so many queries on my channel that how do we clinically assess a patient? So whenever a patient walks in your OPD chamber or you are meeting some patient, right from the posture of the patient to the look of the patient to the talk of the patient, everything tells you something. So diagnosis starts from history itself, then goes to clinical examination, and then to investigation part. Always proceed like that. First history, then clinical examination, and then investigation. A sum total of all three of these will give you a diagnosis, and when you reach a diagnosis, only then you can devise a treatment. Treatment could be medical, that is with medicines, whether oral or injectable, or surgical. So this is how we see the management part of any disease. So this is my lecture part 1, in which I will be covering the diagnosis part only. Now, history. The patient is coming in and you are trying to talk to the patient. First, be a calm and good listener. Let her tell herself what's going on. First and foremost, as I talked about in the definition of AUB, that the patient should not be pregnant. So number 1 very important step, rule out pregnancy. Either ask her, if she knows, well and good, otherwise we will investigate. Then ask about her bleeding pattern. What is the actual problem with the periods? Which I talked about in my FIGO 1. There was a chart that how many days the period lasts and 1, 2, 3, 4. There were 4 things which I talked about. So we'll have to go to that lecture and listen to it about the complete bleeding pattern. After listening to the complete bleeding pattern, we make a picture in our mind that yes, we are dealing with something. Now the third question will come, that what impact that disease or that complaint has made on the lifestyle of the patient, and what is the degree of weakness she feels in her body. Quality of life. There is a word, quality of life, which is a new thing in our profession, that anything which changes or degrades the quality of life of the patient needs to be treated. Then we ask for a contraceptive history. This is a general gynae history. We always ask. Why? Because placement of copper T and some oral contraceptive pills can lead to AUB. And very important, history of any specific medications or medical interventions, whether she is having some more diseases or problems or she has some treatment history. Now, what are the iatrogenic interventions that I am talking about? It could be in the form of drugs. First of all, do we know what is the meaning of iatrogenic? Iatrogenic means doctor created. Something which a doctor did to improve the quality of life, but it had some ADR or adverse reactions and led to some other problem. So iatrogenic interventions means either some medicines or some devices put inside or some procedures done on the uterus for the benefit of the patient, but at the end she is developed AUB. Now, what are the drugs that can cause AUB? Very important. If the patient tells you, or shows you some prescriptions of the old time medications, how do you know? So drugs affecting coagulation system, very important. Coagulation system plays an important role during the bleeding pattern. So any drugs that the patient is taking because of some other disease like anticoagulants, for example, warfarin, heparin, anything which deranges the platelet activation like aspirin, clopidogrel. These are medications which are generally given on a long time and it can affect the bleeding pattern of the patient. Then there are some medications which affect the endometrium, such as progesterones. Why the patient will be taking progesterones? As a contraceptive, like Depo-Provera or DMPA, depot preparation, injection medroxyprogesterone acetate, which is taken as a contraceptive every 3 months, and progesterone only pill. You have to specifically ask the contraceptive history. Then there are drugs which are used to create therapeutic amenorrhea. In some patients, some doctor must have given some drugs which was supposed to create amenorrhea, but there is something called as breakthrough bleeding, BTB. What is breakthrough bleeding? That in spite of taking this medicine, sometimes irregularly, the endometrium sheds and creates bleeding, such as combined OC pills. Combined OC pills means any pills which contains both estrogen plus progesterone. Then gonadotrophin agonist depots, which were being used to create amenorrhea for some other reason, and agents like Dinogest and Ulipristal. Dinogest is generally used to treat endometriosis and Ulipristal is generally used to decrease the size of fibroids. So there are some very important drugs. So history of any medication or intervention is very important. Now if the patient is using copper T as a contraceptive or post some procedure, a copper T is kept inside and it is creating irregular bleeding to the patient, and LNG IUS, levonorgestrel releasing intrauterine system. This is a very good device which is used to control bleeding, but in the initial cycles when it is acting on the endometrium, initially it causes irregular bleeding. So we always want to ask whether she is carrying any device inside her uterus. Now there are some procedures like TCRE and endometrial ablation. What are these? These procedures in turn are used to decrease the amount of bleeding in patients of AUB. What is this? This is the uterus and the cervix. So transcervical, through the cervix we introduce an instrument to resect the endometrium partially, so that in the long run there is decreased bleeding. But such procedures may lead to irregular bleeding in the initial few months. Then endometrial ablation is something very related to this only, where we introduce a hysteroscope inside and then ablate the endometrium. So treatment history includes drugs as well as devices, as well as any procedures which were being done on the endometrium which are leading to AUB. Now history, how a history tells us that what could be the reason, what picture we frame in our mind. So AUB bleeding pattern study is very important. Once the patient is speaking something about her disease, there should be a diagram in our mind. What? She says that my cycles are predictable. I know that when I am going to bleed, they are cyclical, but either they are very heavy, she is bleeding regularly, but the bleeding is very, very heavy, or she is having intermenstrual spotting, that regularly she is having periods, but in between sometimes there is spurt. What comes to your mind? Since they are predictable and cyclical, that rules out malignancy in most of the cases. It is predictable, that means the hormonal axis is maintained. So if it is very heavy, it could be either adenomyosis or some leiomyoma, which is mostly submucous. Submucous means inside the cavity, which is distorting the cavity. So there is heavy bleeding. Or some other endometrial causes or coagulopathy. I hope you remember the FIGO 2 palm coin classification. So either it could be structural, non-structural. You keep these 4 differential diagnoses in mind. But if she says that the cycle is regular, but intermittently she is getting bleeding, in most of the cases it turns out to be P, polyp. There is some polyp inside the uterus, and off and on it keeps on bleeding. But in the starting, if the patient says that it is highly unpredictable, anytime I start bleeding, most of the time it is malignancy. Now, there are so many tests available, and every test is not suitable for every patient. In which case, which test is to be applied? So first is AUB-C screening. AUB means abnormal uterine bleeding and C means coagulopathy. That means there is some problem with the coagulation profile of the patient. So from the history, how do we take out that this patient may have a coagulopathy? So if the patient gives the history of onset of heavy menstrual bleeding at menarche, very important. Since menarche, she is having heavy bleeding. So there must be some problem from initial time. And such age, at the age of menarche, mostly it is coagulopathy. If this is OR, right? If there is onset of HMB at menarche, then 100% will have to go for coagulation studies. If any one of these events is there, some bleeding events she tells, or she had a postpartum hemorrhage, or surgically related bleeding. In some surgical procedures, she bled a lot. Bleeding associated with dental work. In short, if she gives the history that during some surgical procedure or during delivery, she had excessive bleeding, then think of coagulopathy. Or any two of these, any two. And what are these? Bruising, spontaneous bruising, 1 to 2 times per month. Epistaxis, bleeding from the nose, 1 to 2 times per month. Bleeding from the gums, and family history suggestive of bleeding symptoms. So either from menarche, heavy menstrual bleeding, or any one of them surgically related events, or any spontaneous bleeding from the natural orifices, any two of them. Think of AUBC and please go for coagulation studies. Now with this I finish off the history. So whenever you are talking to the patient, 1, 2, 3, 4, remember, I'll have to ask about pregnancy, bleeding pattern regarding intermenstrual spotting, contraceptive history, any interventions, ask 1, 2, 3, 4 like that. Now, clinical examination. So the patient is sitting in front of you, what will you see? Number 1, general condition of the patient, very important. Whether she is looking comfortable or not, or she is already having tachycardia and tachypnea and she is not looking comfortable, she has a pallor look. Then check the temperature of the patient. Generally we check for infections and temperature. Pulse. Put your hand on the pulse of the patient, and if she is anemic, then she is having tachycardia. So it generally gives you an idea about the blood loss. Then blood pressure. BP is generally decreased if it is a case of acute AUB. She is having too much bleeding that the BP has fallen. Or if the blood pressure is chronically high, then it may be associated with endometrial hyperplasia. We know that endometrial hyperplasia is associated with hypertension and obesity. So keep in mind, if the patient is having hypertension, just give a thought about endometrial hyperplasia. Then comes the BMI. As I told, obesity can be linked with endometrial hyperplasia or PCOS, right? Look for any neck swelling. There may be goiter or signs of hyperandrogenism. What are those signs? Dark discoloration, acne, dark armpits, dark your neckline. So think of PCOS. So just looking at the patient, you can make a diagnosis that whether she is having anemia, what is the blood pressure, what is the endogenous status. Then comes the further specific clinical examinations. In gynecology, when the patient is lying on the couch, first start with the abdomen. After taking due consent from the patient and in the presence of some female nurse, always go for examination. So per abdomen examination, you keep an hand on the abdomen of the patient, and sometimes if she is having a huge fibroid or adenomyosis, you can feel a lump arising from the pelvis coming to the abdomen. Then comes the per speculum examination. Have a good light source, put a speculum, retract the anterior vaginal wall and take a good look at the cervix of the patient. Sometimes you may find cervicitis. There is infection and that's why the patient is having irregular bleeding. Or there is some polyp sort of thing coming out. Have a look, see and then decide. And lastly, go for a per vaginal examination to assess the size of the uterus. It is a bimanual examination. We put one hand inside the vagina, other hand on the abdomen of the patient, and we try to think about the uterine size and we try to palpate the adnexa. What is the meaning of adnexa? The fallopian tube plus ovary. So whether there is some adnexal mass, whether there is some endometriosis, some ovarian cyst, it gives you a very, very good idea. Now you were palpating the uterus and you found that the size was normal, but still the patient is having AUB. What is the all differential diagnosis that comes to your mind? Polyp, either cervical or endometrial or coagulopathy. Mainly these are the non-structural lesions. As the uterine size is normal, there is some other factor working. Or ovulatory disease, endometrial disease, iatrogenic and non-otherwise classified. So generally it is the Cohen part in which you will find a normal size uterus. But if it is enlarged, so it is generally the structural lesion, palm part, fibroid, adenomyosis, malignancy and endometrial hyperplasia. Plain and simple. You don't have to remember things like that. Go from the classification. Structural, non-structural. Anything which is structural will increase the size of the uterus, and anything which is working from behind, which is not seen, in that the uterine size will be normal. Now we have done the history, we have done the clinical examination, and now it is the point, investigations. We cannot prescribe every investigation to each patient. So from history and clinical examination, you need to think that we are going in this direction, and accordingly the array of investigations that we have got are laboratory investigations, that means pathology or blood sample, radiological investigations generally done by radiologists or gynecologists may also do, tissue biopsy. Tissue biopsy we take and then try to find out what is the problem. Now laboratory investigation, first and foremost to be done for all of the patients, that is the complete blood count. Since we are dealing with AUB, that means the patient is losing blood. We need to know what is the hemoglobin status, whether she is anemic. Generally a hemoglobin of less than 10 tells you that yes, she is bleeding more. The peripheral blood film shows microcytic hypochromic anemia. What does that mean? The red blood cells are small in size with less hemoglobin. That means she is losing blood, and the RBCs are not formed nicely. In chronic cases of AUB, sometimes you may find increased platelet count. So if you order a CBC, you look for hemoglobin, platelet, MCH, MCV, MCHC, mean corpuscular hemoglobin, mean corpuscular volume, mean corpuscular hemoglobin concentration to rule out the type of anemia the patient is suffering from. So CBC is to be done for all the patients, and urinary pregnancy test to be done for almost all the patient except for MINAC. But in MINAC also sometimes pregnancy can be found anytime in anyone. So rule out pregnancy, very, very important. Coagulation studies. Coagulation studies, as I told you, wherever you are suspecting AUBC as per the screening table that I had discussed. So if you find, then PT and APTT to be done first. Prothrombin time, activated partial thromboplastin time. Why? Because the prevalence of von Willebrand disease is up to 13% in the population, which is generally overlooked. So if you find that there is some problem with the coagulation, go for the study of VWF, von Willebrand factor, and factor 8th deficiency. But these are to be done once you stop the hormonal treatment, because the presence of given estrogen in the body may interfere with the results of these tests. So stop the hormonal treatment for 7 days and then go for VWF and factor 8 studies, especially if PT, APTT are deranged. Serum ferritin, as you know, that from this we come to know the stores, iron stores in the body. If you are suspecting AUBO, that means some ovulatory dysfunction, some hormonal dysfunction, then go for thyroid profile and prolactin. And prolactin. So you cannot order all the tests in everyone. Just think that this could be a problem and then proceed with this. Now comes radiology. As we know, we are all gynecologists. So ultrasound is the modality of choice for us, right? And if things are not clear from ultrasound, then we go for MRI. But generally in young girls, we go for MRI because transvaginal sonography cannot be done in young girls. So either it could be transabdominal or transvaginal. Either we put the probe over the abdomen or we go from the vagina. Going from the vagina is always better because we go very near to our target organ and then try to see what is the problem. So TVS is the investigation of choice in almost all gynae problems. Normally we get 2-dimensional images in TVS and it generally gives you a good diagnosis. But if it fails or we are lacking somewhere, we can support it with 3-dimensional TVS or saline infusion sonography or color Doppler. I'll be talking about each and every one of these. But what are we trying to evaluate with all these things? We are trying to evaluate the uterus. Now this is the uterus, like this. So, and this is the endometrium. So first of all, we are trying to evaluate the endometrium. Number 1, is this having some problem? Number 2, uterine cavity, the place in between the both endometrial strips. Number 2, is the cavity is having some problem? Or 3, the uterine musculature. So always when you study a report, look for three things: endometrium, uterine cavity, and uterine musculature. Now how do we study? This is something called as the EEC, endometrial echo complex, seen in the sonography. Endometrial means pertaining to endometrium, echo, that echogenicity created by the sound waves. So this is the uterus. It looks like this in a transvaginal scan. This is the anterior endometrium, this is the posterior endometrium, and this is the cavity. So if we zoom this, the gland, stroma, and the whole endometrial stripe is visible. So we generally focus on this area to look at the endometrium. So the endometrial echo complex, it shows mainly the endocrine status of the endometrium. How? If it is a proliferative phase, what does that mean? That there is only estrogen in the body. At that time, the endometrium will show a typical trilaminar appearance. There will be one line of the anterior endometrium, one of the posterior, and the line between them looks very specific. There is no high echogenicity. It is very, very light seen. So proliferative in estrogen predominant stages. Just by looking at the endometrium, you can say that, oh, this patient is not having progesterone. But once the progesterone comes, this whole things becomes like this. Highly echogenic thoroughly. So this is trilaminar and this is not. Looking at the EEC, you can say that this is estrogen and this is E plus P. So E plus P itself rules out anovulation. So just by looking at the EEC, you can say, oh, there is progesterone. So stop thinking about anovulation. Now what is the cutoff of EEC? Where do we feel that this patient is having hyperplasia or not? So 12 mm in the cases of premenopausal patients and 4 mm in cases of postmenopausal. Very, very important. You are getting everything, but the thickness is too much. There is something. If it is trilaminar, thickness is too much. There is no progesterone. There is estrogen. The estrogen is unopposed. Think of ovulation, anovulation, probably PCOS. But there is progesterone. Still, the thickness is too much. Either there is polyp or some hyperplasia. So whenever this cutoff is crossed, think of some endometrial pathology. Now uterine cavity. See, this is the uterine cavity. Endometrium we already assessed. Endometrium is just the lining. But what is lying inside the cavity? It could be a polyp, right? Or it could be a fibroid, a leiomyoma. If you have not gone through the fibroid class of this channel, you can go through that class. In that, I have given all the types of fibroid. So type 0 to 3 of fibroid is mainly pertaining to the uterine cavity. Anything which is protruding, popping inside the uterine cavity, you will have to look for this because this is the thing which mostly interferes with the bleeding. But normally in 2D transvaginal sonography, this is opposed and you are not able to make out that whether it is endometrial hyperplasia or a polyp or a fibroid. What do we do? The answer is saline infusion sonography. It is a marvelous technique and it gives you a very, very fair idea that what are you dealing with. I'll be talking in a short while. Color Doppler helps, but hysteroscopy is the gold standard. What is hysteroscopy? You introduce a scope through the cervix inside the uterus and from your own eyes you see it is a polyp, it is a fibroid, and at the same time you can treat the disease. So see and treat. See and treat. So for uterine cavity, start with transvaginal sonography. If you suspect something, you can go for SIS or color Doppler, but hysteroscopy is gold standard. This is a picture. This was your uterus. Now, the endometrium, it may have a polyp, it may have a fibroid, but definitely the size is increased. The moment you introduce some saline from the cervix inside the cavity, the whole cavity is filled with saline and this thing stands out from behind. Now we see that yes, there is something. So this is saline infusion sonography. Coming to hysteroscopy, it is a random picture, right? So you put the hysteroscope inside. This is the anterior wall of the uterus. This is the posterior. And the pathology is right there in front of you. You are able to see the pedicle. You are able to see the base. Just go and resect. Now comes the last thing, uterine musculature. So this was the uterus. We have studied the cavity. We have studied the endometrium. Now we are talking about the musculature. So mainly musculature is affected in two things, adenomyosis and leiomyoma. Adenomyosis, you find a complete enlargement, which we have already taught in the adenomyosis lecture. And leiomyoma. Which leiomyoma? Type 4 onwards. That means pertaining to the mura, intramural or protruding outside. How do we differentiate? Sometimes they look same. So now comes the role of the color Doppler. What is color Doppler? It basically shows you the blood supply, blood vessels. So if it is a fibroid, the blood vessels will be surrounding the fibroid. But in cases of adenomyoma or adenomyosis, they generally run vertically. So just by putting on the color in your machine, you can find out whether it is a leiomyoma or adenomyoma. What other information can we gather from color Doppler? AV malformations. See, these are rare things, but if you find them on color Doppler, then you can treat them. So arteriovenous malformation, some atypical endometrial polyp or malignancies. If doing all this does not give you any conclusion, then we can proceed for MRI, right? As I told earlier also, hysteroscope is now the procedure of choice to see the cavity and endometrium. Earlier, it was an invasive procedure. It was done in operation theaters under anesthesia. But now with the invention of smaller, more friendly scopes, you can do it as an office procedure with minimal pain to the patient and very, very good diagnosis and treatment. Now we are moving to tissue biopsy segment. Cytology as well as tissue biopsy. Pap smear or cervical cytology. Generally we have a bimodal distribution of cervical cancer early in the age around 30 to 39 and late in the age around 60s. But as a regular screening protocol, please go for pap smear and go for cervical cytology, mainly in cases of post-coital bleeding, where the patient is saying that there is bleeding post-sexual intercourse. Think of carcinoma, think of some pre-malignant lesions. Cervical cultures and wet preparation. These are generally skipped, but they are very important. In cases of chlamydia or Neisseria gonorrhoeae infections, where the cervix is infected, there may be AUB, there may be off and on spotting, white discharge. So always rule out infection. Finally comes endometrial biopsy. Endometrial biopsy means what? We want to see that what are the histopathological changes going inside the endometrium. So we need a sample of this endometrium to be sent for histopathological examination. How do we take out the sample and in which patient should we go for biopsy? There are two questions. So first one, how do we take out the sample? Earlier it was a blind procedure called as DNC in vernacular language, dilatation and curettage, where we used to introduce a curette instrument inside and blindly take out the endometrium. But what was the problem? We don't know where is the pathology. We are just going inside and taking out something. It may miss. Then there was a PIPEL thing, which can be done as an office procedure. DNC was generally done under anesthesia in the operation theatre. But as a screening tool, we can go for PIPEL biopsy, which is a plastic cannula, which is inserted with minimal discomfort to the patient, and a syringing sort of thing is done and an endometrial sample is taken out. But hysteroscopy guided biopsy is the gold standard. Go inside, see the lesion and take the biopsy from that. Now, where do we want endometrial biopsy? We cannot go for biopsy in every patient. These are the parameters. So, age. If the patient is more than 45 years and having some endometrial cause of bleeding, go for biopsy. Weight. Why weight? I told you, look for the BMI. Obesity is generally associated with endometrial carcinomas. Bleeding pattern. Irregular. In the initial time, in the history I told, if the patient is saying that I am having non-cyclical, unpredictable, irregular bleeding, think of malignancy. She is taking medical treatment but not responding. Go for biopsy. Medical conditions. Which medical conditions? Chronic anovulation, infertility or diabetes. See, diabetes plus hypertension plus obesity, a classical triad of endometrial carcinoma. So if you find any of them, go for endometrial biopsy. And chronic anovulation means chronically the endometrium is exposed to estrogen, unopposed estrogen, and there is no progesterone. It can lead to hyperplasia and carcinomas. Family history, very important. First degree relative having endometrial carcinoma or some syndrome such as Lynch syndrome, go for a biopsy. Iatrogenic cause, you have given unopposed estrogen to the patient, go to a biopsy. Tamoxifen therapy, and in ultrasound, in cases of premenopausal 12 millimeter, postmenopausal 4 millimeter. 12 millimeter in premenopausal, 4 millimeter in postmenopausal. Go for a biopsy. Please remember these points. What are the cutoff? What is the parameter? When will we go for endometrial biopsy? 1, 2, 3, 4. As I told, in clinical examination history, age of the patient, BMI of the patient, blood pressure, the history, everything tells you where to go for a biopsy and where not to go for a biopsy. So with this, I finish off the lecture. Hopefully, through this, from history to investigations, now we are able to diagnose the patient and stamp what is the diagnosis. After stamping the diagnosis, in the next lecture, I'll be covering the treatment part, both medical as well as surgical. Thank you so much.